Hi, my name is Michaela Rao, and for this week's lab presentation, I'm going to focus on the lower limb. So, the lower limb can be divided into four segments. Starting superiorly, we had the gluteal region, then the thigh, then the leg, and lastly the foot, which is most inferior to the ground. I'll be focusing on the gluteal region and the thigh and knee for this week's lecture. So, there are 7 muscles that make up the gluteal region of the lower limb. These muscles can be divided into the superficial muscles and the deep muscles. The superficial muscles of the gluteal region are the gluteus maximus, gluteus minimus, and gluteus medius. These 3 muscles can be seen as 3 different layers, stacked on top of each other. The gluteus maximus is the largest muscle and most superficial. It attaches from the posterior surface of the ilium to the greater tuberosity of the femur. This can be shown outlined in blue on figure 1. The gluteus medius is a fan-shaped muscle that is located in between the gluteus maximus and minimus, which forms the second layer. It attaches from the ilium to the lateral surface of the greater trochanter, as shown in green in figure number 2. The best way to fully see the gluteus medius is to flip over the gluteus maximus during a dissection. The third layer is the gluteus minimus. It is the deepest and smallest of the 3 superficial muscles. It attaches from the ilium to the anterior side of the greater trochanter as shown in pink in figure 3. The gluteus maximus's main form of action is hip extension and lateral rotation. It's mainly used when force is put upon it, like during running or climbing. The gluteus medius and minimus have the same action. They abduct the hip and medial rotate it. These muscles work together to prevent the pelvic drop of the opposite limb. The gluteus maximus is innervated by the inferior gluteal nerve, while the gluteus medius and minimus are innervated by the superior gluteal nerve. Damage to the superior gluteal nerve, which innervates the gluteus medius and minimus, can result in a pelvic drop. One of the main functions of the superior gluteal nerve is to stabilize the pelvis during locomotion, for example, when a person is walking. Damage to this nerve will paralyze the gluteus medius and minimus, and that's what unstabilizes the pelvis. If the damage is on the person's right side, the pelvic drop will result on the left side and vice versa. The deep muscles of the gluteal region contains the piriformis, obturator internus, and quadratus femoris. These muscles are formed underneath the gluteus minimus. The most superior of the deep muscles is the piriformis. It attaches to the anterior surface of the sacrum to the greater trochanter of the femur, as shown in blue in figure 1. Inferior to the piriformis is the obturator internus. It's a triangle-like shape that attaches from the obturator foramen, goes through the lesser sciatic foramen, then to the greater trochanter of the femur, as shown in green in figure 2. The quadratus femoris is a square-shaped muscle inferior to the obturator internus. It attaches from the ischium to the femur, as shown in figure 3. All of these 3 muscles laterally or externally rotate and abduct the hip. Before moving on to the thigh muscles, there's one bone that I want to discuss. This is called the femur. The femur attaches the pelvis and is proximal to the knee. It has a ball and socket type synovial joint which allows the head of the femur to attach to the acetabulum of the pelvis. The distal part of the femur contains the lateral and medial condyle which create the knee joint, and that will be discussed later in this lecture. So, starting superiorly, there's the head of the femur, which attaches to the acetabulum, like I just said. And off of the head contains the neck of the femur, which connects to the shaft, the largest part of the bone. Attached to the shaft are the greater and lesser trochanters, and inferior to the shaft are the lateral and medial condyles. So now we're going to focus on the anterior thigh muscles. The rectus femoris is the largest muscle that runs straight down the thigh and attaches to the tibial tuberosity of the knee. On the lateral side of the anterior thigh is the vastus lateralis, and medial to the thigh is the vastus medialis, as their location is represented in the name itself. Vastus intermedius is right underneath the rectus femoris, but it's not shown in the picture. It is more one of the deep muscles of the thigh. The three vastus muscles come together to form the quadriceps tendon. The three vastus muscles plus the rectus femoris form the quadriceps femoris. The iliopsoas is made up of two different muscles that come together as one tendon, the psoas major and iliacus. The sartorius is a long S-shaped muscle that attaches laterally, then wraps around the anterior side of the thigh and attaches medially. It's rested on top of the other muscles. The anterior compartment is innervated by the femoral nerve. Here we have a picture of a human cadaver where four of these muscles are defined. Number one is the sartorius. As you can see, it starts laterally, wraps around anteriorly of the thigh, and finishes medially. Number two is the rectus femoris. Number three is the vastus medialis, as it is medial to the thigh. And number four is vastus lateralis, as it is on the lateral side of the anterior thigh. The femoral artery is the main blood supply to the lower limb. This artery becomes the popliteus artery when it passes behind the knee, which we'll discuss later. The femoral nerve is right next to the artery. And the femoral vein, too, is also next to the artery. The great saphenous veins drains into the femoral vein, and it hangs by the lateral side of the thigh and is a huge vein traveling all the way down to the foot. Next, we're going to focus on the medial thigh muscles. So if you look at the picture in the last slide of the femoral vein, you can see that there's a muscle right next to that, and more medially, and that muscle is called the pectineus muscle. It's a triangle-like shape. Below the pectineus are the adductor muscles, the adductor brevis, longus, and magnus. Adductor magnus is the largest muscle of the medial compartment, and it lies posteriorly to the other muscles. Adductor longus is a long, flat-like muscle. And adductor brevis is a short muscle that lies underneath the adductor longus. The gracilis is the most superficial and medial of the medial compartment of the thigh. It can sometimes be used to replace a muscle into the hand or forearm. These medial thigh muscles are innervated by the obturator nerve. This is another cadaver image of the picture of the medial compartment of the thigh. Number one represents the adductor longus, number two represents the adductor magnus, and number three represents the gracilis. Now we're going to move on to the posterior thigh compartment of the muscles. There are three posterior muscles that are important. The first one is the biceps femoris, and as according to its name, bi means two, so this muscle contains two heads, the long head and short head. Biceps femoris is the most lateral of the posterior muscles. Then we have the semitendinosus, which lies medial to the biceps femoris and covers most of the semimembranosus. Semimembranosus lies underneath the semitendinosus, as we had just spoken about, and this muscle is flat-like. These posterior thigh muscles are innervated by the sciatic nerve. Here's another picture of a cadaver showing the posterior side of the muscles. Number one is the biceps femoris, number two is the semitendinosus, and number three is the semimembranosus. So as we have learned in lecture, the sciatic nerve can build with pressure. Once this happens, this forms the sciatica. If there's too much pressure radiating along the sciatic nerve, it can radiate pain down the back of the leg. This can also be caused through herniated discs. Usually the pain can last for 2 weeks, and in order to treat this, people should either bed rest or do the complete opposite and stay active, or if worse comes to worse, they can use analgesics or non-inflammatory drugs. Sometimes it is also best to do a surgical intervention, and in this case, the focus would be to remove the disc herniation that is causing the pressure of the nerve. The posterior thigh compartment contains the popliteal artery and vein. The femoral artery from the anterior thigh becomes the popliteal artery as it passes through the adductor hiatus behind the knee. A great way to organize the thigh compartments is to create a compartment table like the one shown above. As you can see, the table is divided into muscles, attachment, action, and innervation, and each muscle is color-coded so it's easier for the eye to locate the necessary information. All in all, the anterior compartment flexes the hip and extends the knee. The only exception that a muscle has for this action is the sartorius muscle, since it wraps around the lateral side into the medial side of the thigh, so it flexes both the hip and knee. It does not do any sort of extension. The medial compartment adducts the hip and flexes the knee, while the posterior compartment extends the hip and flexes the knee. Now we're going to move on to the knee. So as you can see, the femur connects to the tibia and fibula of the knee. The lateral condyle of the femur, as we already saw, connects to the fibula, and the medial condyle connects to the tibia. The patella is on the front, and I like to compare it to a shield of the whole knee section. The knee has two collateral ligaments, the lateral collateral ligament and the medial collateral ligament. The lateral collateral ligament, or the LCL, attaches from the femur to the fibula, and the medial collateral ligament, or the MCL, attaches from the femur to the tibia. These two ligaments prevent abduction and adduction. Therefore, by preventing these actions, they create a knee joint. MCL tears are often very common, especially in athletes. Direct contact to the outside of the knee can push the knee sideways and put pressure on the MCL and tear it. A tear to this ligament can cause pain, swelling, and instability to the knee, since the MCL helps stabilize the knee by preventing adduction and abduction. In the image, you can see that image A represents a normal MCL, while image B represents a torn MCL. The black squiggly line pointed by the red arrow is the tear. Usually, icing the part will help bring down the swelling and relieve the pain, and the tear can heal itself. However, in some cases, surgery may be needed. The knee also has two cruciate ligaments, posterior cruciate ligament, or PCL, and the anterior cruciate ligament, or the ACL. These two ligaments cross each other at the middle of the knee, hence why they're called cruciate ligaments, because cruciate means cross. The ACL attaches anteriorly on the tibia, then goes posteriorly and attaches posteriorly on the femur. The PCL attaches posteriorly on the tibia, then goes anteriorly and attaches anteriorly to the femur. The ACL is tight in extension and prevents anterior dislocation of the tibia on femur, while the PCL is tight in flexion and prevents posterior dislocation of the tibia on femur. Lastly, we have the menisci, the lateral meniscus and the medial meniscus. The lateral meniscus is on the lateral side of the knee, closer to the fibula, while the medial meniscus is on the medial side of the knee and closer to the tibia. The medial meniscus and MCL are attached. However, the lateral meniscus and LCL are not, due to a muscle called the popliteus muscle. This muscle is a tendon that lies in between the lateral meniscus and the LCL. Another fun fact is that there's padding between the condyles and the tibia called the fibrocartilaginous pads. It's not shown in the picture, but it helps provide padding between the condyles and the tibia. So that was the end of this lecture. Hope you guys enjoyed it. Thank you.